by handing over to Tracy. Thanks, Tracy.
Thanks ever so much, Matt. Good evening to you all. It's a huge pleasure to be with you, and as is ever the case, it's always a huge privilege to be asked to talk at such events. I will start by saying I'm not an academic, nor am I an emergency planning expert. There are plenty of people out there with a great deal more expertise than mine. But what I will share with you is my thoughts on public health leadership in the context of my own experience. And that experience has been gained working alongside some of the most incredible people in this sector. So I'm happy to share our collective expertise through the lens of public health leadership. The conversation this evening is timely. The brilliance of public health has really been brought to the fore. I don't think there's ever been a time where we have heard the words public health spoken so frequently within our popular press, and nor has there been a time when we've talked about the fantastic work of national, regional and local public health teams with such accolade and recognition for the work that they're doing, and I am certainly privileged to be part of that. The world at the moment is facing a national threat and an international threat, and what we are doing together is working on this through many strands of work and through many pieces of policy and changes, and it's a fast-moving environment that we're all working hard on. So I'm going to not be talking about COVID extensively this evening, but it'll be hard to get through the next 35 minutes or so without a mention, I'm sure you'll appreciate. And I'm also not going to be focusing exclusively on the events in 2018 around the nerve agent incident in Salisbury. However, this will also get a mention. And we'll be talking about it in terms of using this as a demonstration of the public health leadership that took place and talking about public health leadership in action. So that's what it's not. What it will be is an interpretation of public health leadership in times of crisis, the strength, the rigour, the evidence that we draw on, and the discipline that public health brings. Its strengths, the challenges, and why it matters so much. And also the areas where public health is part of our lives without us even realising that public health is the factor that's driving those things. Public health is broad and varied. And if we could move on to the next slide. We often talk about the variety of public health, and we talk about the art and the science of public health. And we have many things that are business as usual and the things that we're working on day by day in all factors. But generally, we also have things that happen at short notice that need fast response. And like Forrest and his box of chocolates, we never know what we never quite know what we're going to be getting. Next slide, please. I will say I've only got a few slides. I'm not going to be saying next slide, please, all night. I'm sure we've all had our fill of that. What we define as disasters comes in two main categories, the natural disasters and the man-made. Natural disasters are those that are naturally occurring. This could be earthquakes, flooding, bushfires. We're seeing an increase in natural disasters from extreme weather events caused by environmental change. These are more frequent and more varied, and the impact is greater. The aftermath is often devastating. California most recently provides a recent extraordinary example of the types of extremes that happen within our weather, where we've seen raging wild bushfires quickly change to snowfall that has paralysed the entire state. Pandemic and infectious disease also sits here in this natural phenomenon, such as COVID being one of them. Man-made disasters also are those that we need to work on. And in this space, we look at warfare, terrorism and structural collapse, all things that we would need to look at in terms of disaster management. So a big part of this is leadership, and how we lead through crisis is vital. And our approach to this is something that we spend a lot of time training on and practicing. Public health leadership happens across many things, huge disasters such as those just mentioned, but it also has a huge role to play in many factors and just our ordinary social lives. It's a big driver for social change in terms of looking across the way we live our lives and also behaviour change. As Matt talked about in the introduction, my early career was within HIV, and the HIV sector at the height of the epidemic, the pandemic, was an interesting place to be. It was a place of learning. It was HIV and AIDS had been around when I started working for about 13, 14 years. From that early diagnosis in the early 80s, I sort of joined the sector in the mid 90s, so just after the first combination therapies started to come on board. But treatments at that stage were quite brutal and quite difficult to adhere to. And people experienced huge stigma. So it wasn't just the impact of having a HIV diagnosis that caused difficulty for individuals who was diagnosed. It was the huge social impact as well, in terms of loss of jobs, loss of family and friends, and also loss of tenancies because of the stigma that was around it and how unknown it was. So the complexities of some of the things we're working on isn't just about dealing with the core crisis as it presents itself, it's the associated factors. HIV took a long time for us to really understand, and we're still learning at the moment in terms of its genomic structures, but also how HIV affects the human body. And this is similar to any new condition, and COVID would forward this. Scientists moved very quickly to get an understanding of COVID so that we could start testing for it, potentially start working on treatments, and as has been in the news this week, the hope of a vaccine. It took longer with HIV, and part of that was about what we knew about it, the kind of communities that it affected, looking at how people were more at risk. And we're also seeing this with COVID. There's huge similarities. We're seeing people disproportionately affected by COVID. And we need to think about the social conditions in terms of how these differences occur and really try and understand them. Any pandemic, any infectious disease is complex. Working with people living with and affected by HIV was the sort of start of my career, and it was that exposed me, I suppose, to health inequalities and my first introduction to them. And it was really the baseline for what has been my interest throughout my career in terms of tackling inequalities and dealing with vulnerability, not just how it presents itself, but understanding where those vulnerabilities are formed within our communities and how communities and individuals deal with those and how we build greater resilience for people, but also about how we view groups. I've done work where the risk of harm of, say, antisocial behaviour has been at play, and particularly in young people who are seen as perpetrators of antisocial behaviour, but actually when you look behind the surface and what's really behind that is they're not perpetrators at all, there's criminal exploitation, and actually what there is a huge amount of vulnerability. So our role in public health is really to look behind the presenting vulnerabilities and understand the root cause of those and how we can really make a change to tackle those. Part of public health, in my view, and public health leadership is about working with the most vulnerable. Whether it's the fight for equality, about preventing exploitation, or whether it is about preventing risks both within our public and private spaces. And we hear a lot on the news about violent crime, so whether it is about knife crimes and gangs and how young people are recruited into gangs, or whether it is about domestic violence and abuse, control and coercion that happens very much in our private spaces, the very spaces that should be our safe place. But also understanding the consequences of these issues. So we know about 50% of children that are on child protection registers have domestic abuse as a factor. So how we think about public health within the context of safeguarding and really truly protecting every aspect of our population's health and well-being in that very broadest sense. So for me, it isn't confined to lifestyle behaviours, but but also has a huge role in understanding the risk within the places that we live and work, our networks, and how we live. I avoid statements like lifestyle choices, as choice in itself can be debated. For example, people living on limited income and making choices between heating their homes or feeding their children have a very different access to choice than somebody who's independently wealthy. So public health leadership is about how we bring the golden threads of how our communities live and what the foundations of our society is, really understand the need and make sure that we're able to build the services with our communities, for our communities. COVID has really shone a light on health inequalities and the disproportionate impact on different community groups. This is a topic of conversation that is ongoing. Conversations have turned a lot to what it will be like in the post-COVID world. And COVID has been sort of labelled as the cause for issues. I personally can't remember living in utopia prior to COVID. We were dealing with things like deprivation, health inequalities, violence, poor health, whether it's through disease or whether it's through lifestyle. All of these things existed. We also see higher cases of certain illnesses amongst different groups. All of these health inequalities were present prior to COVID, but COVID has certainly exacerbated some of these issues. And what we will need to be doing over the next weeks is think about how we lead into recovery and start that planning to take us forward. What we also understand about COVID is many protective factors have been put in place to interrupt the chain of infection and to keep our communities safe. We have a set of new rules that we now live by, and obviously we're in lockdown at the moment, so those rules are at their strongest at the moment, and the importance of compliance to those rules. But we also know for some, those very protective factors will have actually exacerbated risk. For example, in the case of mental health, those people that are used to routine need certain touches in terms of their support networks. And we know that these protective factors for COVID will have made life quite difficult for many in our communities, where a change to routine can be really, really harmful and hard to manage for some people. There are also reports and newspaper articles around domestic abuse, and headlines such as lockdown being the biggest nightmare for victims, and how being trapped with your perpetrator is bringing increased fear. We talk a lot and we hear a lot in the news about the economic impact that COVID will have, and those that are already living in deprivation will feel this most. We see this play out. All of these things are the focus of public health. Only about 10% of our health is dependent on healthcare and services, and the rest is about genetics and the way we live, the networks that we mix with, and the complexities just of our lives. We need to prioritise these things that influence our ability to stay well, and healthy weight, not smoking, reducing alcohol are all part of that. But we also know people living under threat, those who are lonely, those without a job or a secure tenancy, will not be able to prioritise healthier lifestyles. So our starting point has to be everyone has a home, a job and a friend. Next slide please, Sophie. So we've talked a little bit about the job of public health being a large one, and I'm not quite sure where the parameters of it are really. I've never quite been able to work out where the job ends. As Director of Public Health, I had about 144 strands of work that I looked after with my fabulous team in Wiltshire. And what public health has done throughout history, from sanitation through to vaccination to the introduction of seatbelts being compulsory in cars. I was a child of the 70s and I certainly remember rolling around the backseat of my family car without being unchecked. And the smoking ban, the list goes on, and not everybody knows that these interventions are public health interventions. As part of the day job, all of these things into play, and we put in place interventions around all sorts of programmes that are there to improve health outcomes and wellbeing for our populations. And we're also one of many agencies that show up when major crises happen, whether that be pandemic flooding, chemical spills, fires, and sometimes the unthinkable, such as in March 2018. At this point, I was the Director of Public Health in Wiltshire, and remember clearly the call coming in that would set the wheels in motion, that would set up the work programme really for the next many months. What was revealed over the next few days around this incident after finding Sergei and Yulia on that bench in Salisbury, which I'm sure you have all read about in the media. We would find out over the coming days that it was a nerve agent that had been used on Sergei, who had been an ex-Russian spy. And it was unthinkable that something like this could happen in peacetime anywhere in the world, in England and within the beautiful medieval city of Salisbury. And it led to the eyes of the world on that small city, and lots of facts that none of us particularly knew. I know I didn't, but during the course of this, obviously that spire is 123 metres high, and it is indeed the tallest spire in the UK. Every crisis starts with sense making, understanding the situation, the hazards, and defining the risks. The part of the incident was intense and fast-paced and changing, and there was lots of strands happening at the same time. The emergency phase in any crisis is influenced by the situation and the relationships that existed before the incident occurs. Those of us that work in public health, we're part of a system of training and exercising and practice in readiness for events taking place. And we practice our response on all sorts of potential issues. These sessions can feel elaborate and over the top, and the exercise takes you to the edges of what you think are reality to make sure we're ready for any eventuality, or at least have the transferable skills that we can draw on in any situation. What I've learned over the last 2 or 3 years, however, that nothing is elaborate and fact is certainly stranger than fiction. The systematic approach to planning and practice means that when incidents happen, we have what is needed in place. There's a great guy who we work with in Wiltshire as part of the local resilience forum there, and he always talks about us dealing with the unusual in the usual way. And it almost became our mantra. When 2018 started with this incident, it was certainly unusual, and that many of us had a great deal of experience in dealing with incidents of varying kind, but this was an unusual one. However, our core skill set was what was needed. We went through the usual process and followed the incident through. In any situation, it's important that we mobilise early, and again, this comes down to strong leadership. And you mobilise early based on evidence. This will evolve, it is certainly not static, and you need to be able to act. There are often concurrent issues within any incident. It won't just be the public health factors. There could be infrastructural damage, service disruption, business closures, economic risk, and police investigation. In 2018, I think we just about had all of these, and they were all as important as each other. But public health takes primacy, and the protection of life is paramount, and that is what stayed core throughout the incident. 2018, like many major incidents, had multiple agencies working on the issue, all with a slightly different set of objectives, but there is a collective aim. Because there are multiple strands in play, there needs to be distributed leadership. So many of us had a variety of leadership roles within there. So all of the expertise from the room is brought together, and each voice of each of those experts is heard equally. The hierarchy within those voices leaves the room. This needs to happen without conflict and with respect, and to value each person's perspective and what that brings to the conversation. This worked really well in 2018 as we worked without ego, rank, or self-interest. There were 27 agencies involved, all bringing their expertise, identifying the risks from their specialism and offering the mitigation. Each were heard, and there was consistent collaboration throughout, where everyone was valued and the voices of many were assimilated through a core set of processes and principles, all moving the response forward. There are, of course, no decision makers in the room, and certainly the chairs of the various strands of work going on conducted the information as it come through. So decisions were made that drew all of that information together, but no decision was made in isolation and none without rationale. If we move on to the next slide, Sophie, thank you. So adaptive leadership also comes into play. situations aren't static, and therefore the approach has to be agile. There's also an interplay between the internal decision making and what is happening within the response room, but with it also with external engagement. As you see, I'm not a great fan of words on slides. I tend to use pictures only. And the key thing we talk about in public health a lot is the public health paradox. There isn't a picture for that. So if I say this in my native Birmingham tongue, it's a paradox. So this is the picture for paradox. I've been quoted now 3 different times where everybody's using paradox for paradox. It seems to have caught on. Your greatest skill will be communicating the messages that appear contradictory. And while certainly in 2018, a lot of our messages through good evidence to the wider public was the fact that the risk to the public was low. And this was very much a truthful message and one that was well publicised. But this message was going out to a backdrop of soldiers arriving on the streets of Salisbury to start the decontamination process, wearing hazmat suits. So it's how do we communicate by assimilating what could be contradictory or paradoxical information. The incident is live and changing, and therefore communication, particularly with those directly impacted, is essential. Gaps in information get filled with by imagination, and this can lead to much greater anxiety and impact. It would be an error to operate a response within a professional vacuum at the exclusion of external stakeholders, and this has to include the communities themselves. Moving from response into recovery, I led the community engagement aspects and chaired the health and wellbeing cell. Recovery can take a long time, and the practical aspects such as bringing services back on board and returning buildings to use will happen far quicker than the pace of human healing. There's plenty of literature that speaks about recovery starting for people 2 to 5 years post the incident, so it's not immediate. People aren't getting to the start line in terms of their recovery whilst the incident is live. It's only after reflection that they can really start to think about this. Therefore, you have to plan long term. Recovery structures need to stay in place to support this. Recovery takes a long time, requires a different skill set and focus to that of response. And for a while, response and recovery need to run in parallel, as you need to be planning for recovery from the beginning of the incident. It's not something that starts when response is over. It starts at the very beginning. You have to move swiftly between the different requirements of looking through evidence and drawing on opinion to that of needed to work alongside a community in distress and provide information within their context so they can make sense of what is happening to them and around them. I've been criticised for getting involved in this element during 2018 and being too personally available to people that were affected and impacted by this. But I needed to be part of the community to inform them during response so they knew what would happen. And to be honest, on reflection, I'd do exactly the same if it was to happen again. You cannot appear in the height of a disaster and then walk away just because the apparent dust has settled. People are left with a lot of emotional rubble that will take much longer to brush away. Irrespective of what the incident is, whether natural phenomena such as pandemics or flood, HIV, the flu pandemic of 2009, SARS in 2003, incidents of biowarfare or terrorism such as the anthrax attacks in 2001, Grenfell, the Manchester bombing, 7/7, the element that is most scrutinised will be leadership. Charles Steen, who's the Vice Dean of Public Health and Community Engagement in America, talks about the issue of responsibility and blame and how these don't get enough emphasis in training, but are seldom forgotten about in practice. Blame often follows crisis. This needs to become part of our learning, and we need to assess ourselves in training and exercises through the lens of others, and through this be able to learn more about the gaps we leave and better placed to mitigate them. Nor do we put enough emphasis on understanding the complexity of recovery and the different set of skills needed here, and that it is likely to be the same workforce who will be exhausted from the response and need to be re-energised to occupy the space for far longer. Public health leadership has a role in ensuring civil contracting is in place during the response. And we've seen some of this during the COVID response. We've seen Swindon, for example, talking about we're all in this together. That's civil contracting, bringing their community with them around their comms plan. And that has been replicated up and down the country, where we're seeing really good examples of working with communities, so that this is about all of us, become part of it, become part of the solution, and making sure that the community are part of every detail of this. And within that, they also need to be part of the solutions for recovery. This will enable a tiered approach to public protection and include communities in the process iteratively. So this is an ongoing dialogue that happens throughout. This then opens the door, as there will be established relationships, to that collective rebuild of communities and support individuals with the focus on people. There'll be plenty of eyes on the buildings and services and the economy, but public health spans the health, place and economic regeneration of both response and recovery, and puts improved health and wellbeing as the outcome through this collaborative leadership. Next slide, please, Sophie. Above all is compassionate leadership. The King's Fund have recently published on this subject. Their focus is a little bit different in terms of the practice. It's more about health services and care. But the principles apply to working with communities with the focus on inclusion and building connections across boundaries. But compassion also needs to form part of our professional interactions. High-pressured environments lead to high-pressured behaviours. And knowing the people you are likely to work with on a major incident ahead of it and investing in those relationships will pay dividends afterwards, and forgive a lot when you're under the pressure of a response. I remember speaking to a friend during the height of the 2018 first response and just saying, the only people I see are the people in that room, and I feel like I'm going mad. And she said to me, you will know you've spent far too much time in that room when you start fancying them. Thankfully, we must have got out just in time, because I can safely say that I didn't get to that point, although I have made some friends for life. When you're working so intensely with people for such a period of time, the bonds are made and I hope unbreakable. Beyond this compassion is compassion to self. I worked on this incident for a long time, about 11 months really, before I took a break. And the first few weeks were really, really intense. On week 3, not really being home for anything other than a quick shower, a change, a nap, and to just grab a change of clothes, I ran in one day and my son, who was about 12 at the time, was sat at the table. Since he was little, we'd always talked about love feeling like your heart's going to go boom. And it was something that we'd done probably since he was about the age of 3. As I ran into the house, we exchanged a hi, and I grabbed what I'd ran in the house for. And as I left, I got to the kitchen door and I went, love you, boom. And he looked me square in the eye and said, no, boom. It was at that moment I realised I'd been far too absent, but there was nothing I could do to step back into my personal life. He simply turned back to his homework, and in that moment, I left the house knowing it was going to be a little while before I was going to be able to repair the damage that the incident had done within my private space. Working in crisis management is intense, and those doing it now, and there are a cast of tens of thousands that are working on this day in, day out, and it's 7 days a week. You don't get weekends, days bleed into each other. You don't know where one day ends and another begins. And often within this intensity, the days can be 18 hours long. They're not short days, and the only break you'll get is the rest between 2 deep breaths. In these times, you have to know and hang on to the fact that it will come to an end. Think about and plan for your own recovery as the response phase moves away. Build in time for your own crash, because it will come. I took a week out at about month 11, and for that week, I cried and I cleaned my house, and it was my way of getting through it. Cleaning my house was my therapy. You will have other choices, walking, screaming, whatever it might be. And preparing to be aware of your own needs and really planning for these. and be ready to start your own recovery. Make sure you look after yourself while you're looking after everyone else. We can't look after anyone else if we're not giving ourselves at least some of that care. What we do in public health is hugely important, often misrepresented, often misunderstood, and very frequently not given the praise it deserves. But public health leadership is driving forward the health and improvement of our populations in so many ways. And I'm really glad that I get the chance to work and be part of that. Next slide, please. Thank you all for listening.
Thanks very much, Tracy. That was really extraordinary, and you've given me an almost impossible job of trying to respond to that. I mean, it's kind of pointless. You've said it all. I was frantically scribbling notes while you were talking, and I guess where I started was thinking through the kind of leadership, what leadership might have meant from the kinds of things I was taught at school, the kind of the lone hero model of leadership. And yeah, sure, I guess that still has a place. But I guess what you've described is a much more nuanced, sophisticated approach. Core to this is skill and competence at the central public health role. I mean, to be a good leader, you have to know what you're doing. And you've demonstrated that absolutely overwhelmingly. But I think in addition to this technical skill is a set of much more human skills that I think you really, really brought out. Kindness and compassion, inclusivity, humility. It is essential to be able to admit when one doesn't know something. It is essential to be able to admit when one is wrong and to learn from that. The self-reflection and learning that come from that kind of humility is essential to being a better and improving leader. You talked about the public health paradox, emphasizing the importance of communication. And I'm quite heavily involved in the response to COVID-19, and it is absolutely essential. It is hugely important that we as public health professionals really think very hard about the ways in which we communicate things, and absolutely try to pick out these paradoxes. I'm trying to communicate Rose's prevention paradox pretty much every day, talking about the ways in which actions that might seem irrelevant to an individual soon add up and amplify across a population to become really important, powerful things that need to be done. And I guess that as we all grapple with the inherent uncertainty in these problems, the most urgent and pressing of which right now is, of course, COVID-19, but there will always be problems like this. This is not the last pandemic we're all going to have to deal with. It's essential that we listen as well as talk. And as you so movingly described, we also need to look after ourselves as well as others. I wrote down one of the things you said, and I'd like to conclude with that. You said, we worked without ego, rank, or self-interest, and everyone was valued. The lessons from this, I think, could be applied to many leaders around the world, not just those of us working in public health. So I'd just like to thank you again, Tracy, for a really fantastic talk, and certainly inspiring and challenging me to try and do my job a bit better. Thanks very much.
Thank you, Harry. And thank you, let me add my thanks to Harry's, Tracy, for your talk. So we have time for questions. Do please be sending questions in. I've got a stack of questions, so I am going to ask some questions. Let me just see. Okay, we've got a question here that's come in, but first of all, I just wanted to pick up on something you said, Tracy, which was about, well, it reminded me of something Richard Horton, the editor of The Lancet, has described COVID as not a pandemic, but as a syndemic, talking about the fact that there are these kind of biological and social interactions. And that really struck me that what you were saying is quite along a similar lines, that actually there are all these public health issues and inequalities in health along socioeconomic lines, and those were all there before COVID, and they are still all there now. And it's this kind of interaction which is we're seeing that show up in the way in which different groups of people are suffering more. So I just wondered whether, yeah, you could just expand on that. I mean, presumably you agree with that kind of diagnosis of this syndemic rather than pandemic.
Yeah, I read that article, Matt, and it really struck me. And I think it is the conversation that we need to have more of, in terms of health isn't a separate entity to our lives. It isn't over there, it's part of us, and it's got lots of different influences. And I talked about the fact that I really struggle with the notion of lifestyle choice, and because whatever decisions we make about our lives, there are all sorts of factors that influence that, and some of them we have greater control of than others. And that's everything from the amount of exercise we take to the kind of food we eat, but all of that is also influenced by the place in which we live. I mean, I certainly know, I grew up in the Midlands. I moved to Wiltshire back in 2003, and moving the 92 miles I did, I put 11 years on my life. I mean, obviously they won't show themselves, because the first 30 years of my life I spent in the place that was obviously going to be taking years off my life expectancy, and indeed the years I will spend in good health. There's something quite wrong about that, in terms of the fact that where we live will determine not only the length of our life, but the quality of our life. And it's what we can do, not only to close that gap, but to eradicate it. So it's about, for me, we need to have really ambitious conversations about that. Health inequalities are unjust, and the way they present themselves and the way they play out are unjust. So yeah, that article for me said everything we need to be talking about at the moment, in terms of that interaction between our health, the pandemic, and indeed our own personal lives.
I think it's really shone a light for the whole country on, these existing inequalities, and so hopefully that is something that will, be taken forward and be able to be addressed a bit more effectively. So actually it chimes in with a question we've got here that came in. So thank you, Tracy, for a wonderful presentation. This is somebody working with the New York City education system, trying to foster partnerships within the communities that can improve access to essential services like mental health. And this is just wondering, do you have any advice how to successfully outreach within communities to try and improve that access?
This is a conversation we were only having yesterday within the team, actually, in terms of how we do community engagement. We immediately professionalise everything. We use our language, we use our resources, and within that we then want to engage with communities on our terms. Whereas that needs to be flipped on its head, and we need to be working with communities on their terms. And actually it's about them inviting us in, helping them to recognise the needs within that community, and then working with them for the solution. So it comes from within, and how we can get away from over professionalising everything we do. And we do this, we over professionalise and we over medicalise things, and within that in itself becomes a barrier. So it's about how we bring those down and become part of that community leadership for making a change within places, rather than going to them and doing it to them. So it's a huge shift, and it's not an easy one, but it is something about changing the narrative that we have in that place.
I think that really strikes a chord with me, thinking about dealing with kind of socioeconomic inequalities, or by race, and whether this is in access to higher education or whatever it is, the sense that actually what you can't be doing is going in and like, we're the people who are going to come in and fix this problem, but actually that engagement, that community getting alongside, and that co-production, I suppose, of getting people's experience and their inputs into the solutions, rather than coming from the outside and just trying to impose, right, here's how, we're going to fix this like that. So it's really good, interesting to hear you say that. There's another question here I'll just put to you, Tracy. It's slightly different, just going to the Novichok as an incident that took all the attention of yourself in public health in Wiltshire and your colleagues. And when that happened, what happened to all the other agenda items on your list, you know, for public health in Wiltshire? You know, did you find that this was a source of stress, or did you find yourself being able to shut out these other things that you might have been, you know, should have, you know, on another day, if that had never happened, you'd have been working through this list of other priorities? How did that kind of play out?
Really well, if I'm honest. I've said it many times, and I'm sure every director would say the same thing, that they've got the best team. But I know I did have the best team, without question. And the team was incredibly motivated, and yes, a huge amount of our time was put on the incident. But the team sort of split itself into two. So there was focus on business as usual and focus on the incident, and there was a rotation on depending on prioritisation. So things moved along, things carried on, all of the interventions and all of the programmes that we had carried on running. I was absent from that, so I definitely proved myself to be surplus to requirements, because they all just got on with it. So it worked incredibly well, and that is about the professionalism of the people that work there and the skills that people bring. But more than that, and the thing that I've worked in several sort of local public health places, and now obviously within a region. And the one thing that is consistent in everywhere I work, that everybody that works in public health cares, and therefore people always go above and beyond, and they will put in the extra why they need to. And it's how we recognise and value that amongst that workforce, and that is the key. So yeah, it just carried on. It's great.
It's I think that leads nicely on to another question, just thinking about that caring for people, you know, within the team who are responding. There's a question here that says, hello from Canada. And the question asks, you know, given that so much of the public response to crisis is emotional, how do you prepare to manage the emotional reactions that shape the way the public can react to and adhere to public health recommendations? I suppose there's along with that, there's the emotional, you know, response of the team as well. So how do you kind of prepare both those things?
It's honesty, and I think it's being as honest as you can within the parameters that you have to work. There was a lot about this incident whilst it was live that couldn't be shared, and you have to build up trust quite quickly with people, so that when they're asking you questions that you can't answer, you say, I can't answer that, but this is the outcome, that they trust you enough to believe that. So there's a gap in information, but they trust what you're telling them. I was really fortunate because I did so much of the community engagement stuff personally. I built those relationships up right from the beginning of the response all the way through. So each business that was affected, each community that was affected, I was able to get to know and work alongside. And you know, one of the main sites, we would meet in one of the lounges and have the gatherings, because that was the other thing, you couldn't do it in public spaces because you didn't know who was going to be joining you. So it's how you have those conversations and build enough trust that people understand why you can't tell them certain things, but know that you're telling them the truth within that. It's also about expressing your own fears. You know, I'm never afraid to say, I don't know, or I'm tired, or I'm struggling with this. And I did that, and I had those open conversations with people I was supporting, and also within the team who were tired. And of course, I stop, you know, parents become ill, our teenagers need our help, the dog's ill, we're trying to support neighbours, all of the stuff that we normally do and care about, and then you coming into work and being asked to give 200% every day. That's tough. And it's about recognising people's breaking point and saying you just need to step away now. And again, with your team, it's a little bit different because I'd worked with my team for a long time. You know, I'd only been a director of public health a short time, but I'd been in the team a long time. So the relationship existed. So that was already there. And I think progress only ever moves at a pace of trust. And that's key. But with community, it's about those relationships really quickly.
Thank you. There's another question here that is thinking more about the kind of COVID-19 situation and this reconciling between, you know, public health and government having to reconcile the measures that we've got to put in place, I guess the kind of, you know, the lockdown and the restrictions, and the kind of impacts that they have on these pre-existing health and social inequalities. Because obviously, I guess the COVID infection itself has a disproportionate impact depending on these factors, but so does, you know, the lockdown. I don't know. I mean, what's your kind of view on just? I mean, it's. I'm not going to ask you to give an answer as to, okay, you know, how to solve all these problems, but just, I don't know. How do you reflect on that difficulty and yeah, where your kind of experience can play in?
Yeah, I think with any situation like this, priority has to go somewhere, and you have to deal with the thing that's going to do the greatest harm to the greatest number, and that needs to be your focus. But what happens is there is a perception then that everything else has sort of fallen away, and it hasn't. Systems are working incredibly hard to make sure that the needs of everybody are being met. And yes, COVID is is in the foreground at the moment, but there is a lot of work going on. And you know, I work within a system and hear those conversations, and all of this stuff is being thought about and planned for and being put in place. So like with 2018, the business as usual stuff is still happening.
Well, yeah, that's good to know. So lots of comments are coming in that are just saying, you know, expressing thanks for a really interesting talk. So I just want to make sure I express those across, because it's really nice to hear those comments coming in. Okay, so let me just have a look through. A lot of questions that are coming in, so it's quite tricky to pick out. Okay, so actually here's another one that's more of a comment, and it's really, I suppose this is also pertinent to kind of current workers. Someone said, I have a comment, the visualization of Tracy's love for her son brought me to tears, and as a public health worker, our families are invested in public health in an indirect way, and we all need to step back from time to time and invest in them too. So she's thanking, you know, it's reminded, he or she is reminded how much they need to know that now. Thank you, Tracy. And I guess it raises a question really about, we've all been in this, you know, all been in it together and pulling behind the kind of the key workers, the frontline workers, particularly in the NHS. How do you see a danger that actually there's going to be this crash that you talked about amongst, you know, our key workers? And is there something, you know, could there be some proactive intervention to kind of somehow rotate people, you know, get that time off, get that week to do the cleaning of, you know, whatever it is that for particular people, what their thing is, to just step away from the front line and recharge, because otherwise we're storing up a big kind of healthcare worker disaster further down the line.
I think everybody is really mindful of this, and it will happen. It's certainly a conversation that is ongoing in terms of workforce well-being, both now and, you know, over the next few months. But beyond that, in terms of, you know, making sure that people do get the time out when they need it. And at the moment, while we're in the thick of it, that time off is going to be few and far between. But what I would say to people is to try and take those magic moments that you have off, because all of us, you know, and many of my colleagues are guilty of this. We're not aware that we're sort of checking our emails and we'll sort our phone on, and we're sort of checking with colleagues and just texting to see everything's all right. When you're off, be off. You know, if you have got a day off and it could be your only day in 7 that you're getting off, take it and own it and really step away, because that will really help build your resilience. No one can run 7 days a week, even if you're only half in. Because even if you just read an email and that's all you do, it's then in your head and you're mulling it over. So until you can take that week off, just leave the house. I know everyone's meant to do that. I know I'm not the only one that loves housework. Other people talk about walks and things, but I think that's silly. Just clean your house, it's great. And so as you get to that magic week that you can have off, that's great, but you will get more out of that week if you have taken moments of rest along the way when you can.
Yeah, I mean, that's really, I think that's fantastic, fantastic words of advice. And I don't know, do you feel like that your experience with the whole situation from 2018 and having, gone through that intense period for months and months, have you then learned from that then this, that extreme need to, step away, turn the phone off, don't engage with things when you are having the day off? And does that kind of help you and your team be able to respond in a more efficient way, I suppose, to the current situation?
Yeah, it has. It's made me more aware intellectually, I think, and I think I'll always be someone that's more aware of what other people need rather than what I need. But I think, well, I know, faced with the same situation, I'd probably approach it exactly the same way, because it's one of those things that you have to be completely in. But I would make sure that I had those breaks, and I did interrupt it. I wouldn't go for many weeks without taking a day off. And so in terms of that, I would act differently. But I do think when incidents are happening, it's hard to pull yourself away because of the immediacy of stuff. But I hope there would be somebody, well, I know that there'd be somebody alongside me this time telling me to take some time off, which is what I personally would need.
I think that's one of the things, as you talked about earlier, about leadership, and Harry mentioned being that leader to actually say to the people, at times, right, you need to take that rest, take that break. That's very important. There's another question here actually that says, have you got learning from your experience in 2018 that you can see hasn't been applied in this situation? Is there anything, I don't know, I know it's very difficult, these are kind of unprecedented times, but is there anything that you think you could bring that hasn't already come up, that hasn't already been able to be applied yet?
I think they're very different circumstances. It's hard to compare the two. I think what's happening now, certainly from looking at it from a public health place out, what's happened with COVID is there is a unity. I look at the directors of public health across the country and the public health regions, and there is a unity that comes with that. Similarities, approaches, sets of guidance that people are adhering to, which is fantastic to see. And so within that, you've got mutual aid support, because although people are experiencing different things, we've all got different levels of transmission, so different areas are dealing with different things for sure. But what there really is a collective workforce. And I think that if I was back in 2018, I would probably have lifted my head and spoken more to my DPH colleagues, not for any other reason than to have got that professional support. But within the thick of it, you don't do that. But it is such a supportive network that would be something different, but it's happening naturally through COVID. Certainly, I mean, I'm obviously within the Southwest, so I understand that structure a little bit more, and the cohesion that's happening across the public health workforce is incredible.
That's really positive, because it sounds like there is that kind of communication between public health workforces, so that learning, it sounds like the channels are there, so that the learning that different people are having around the country and the experience that they bring is able to kind of flow between the different public health workforces, which is really important. I've got another question here, which is asking for your views on non-compliance with public health regulations or recommendations. And it says, in other words, when people make up their own minds about what risks they are happy to take in their lives, perhaps any advice on how we better communicate or get people to, you know, adhere to these public health recommendations?
Yeah. Compliance is really important, and I think the key message is when you take a risk yourself in terms of non-compliance, you're taking that risk for the people that you're going to come into contact with. And therefore, the compliance isn't just there to protect yourself. It's about us all, and this comes back to this civil contracting. We all have a role in protecting each other. So if you can't do it for yourself, then do it for everybody else.
Yeah, I think, and absolutely, that's and actually the messaging that we have at the moment. You know, I'm always hearing adverts on the radio that are talking about, you know, I wash my hands to protect my family, and I think that in Scotland they had some very effective television adverts that were showing, you know, how you might be fine yourself as a young person. Don't know why I'm pointing at myself for that, but you know, as a younger than me person, but you know, your elderly family and relatives are not going to be okay. And as you say, it's that message of we're all kind of protecting each other by complying. I just want to bring in Harry again, just to think, going back to this idea of the broader kind of public health issues and this idea of, you know, a syndemic and addressing existing inequalities. So the commission that you are co-chairing, Harry, with the Lancet and Chatham House on kind of public health post COVID, presumably these are exactly the sorts of issues that your commission is going to be getting to grips with.
Yeah, thanks, Matt. We're still working out exactly what we're getting to grips with, because we're a small commission working over 18 months and we can't do everything. But I suppose the thing that is motivating us is that there are some really powerful and important common themes underpinning the three big threats to health that we face. That's the environmental emergency, set of environmental emergencies that we face, the current pandemic and any future pandemics, and the existing long-term slow burn epidemic or pandemic of non-communicable diseases, which is kind of getting sidelined at the moment. We've had, I can't remember what the latest figures are, we're up to 1.3, 1.4 million people died globally from COVID-19, but it's over 70 million a year die from non-communicable diseases. And NCDs are largely getting ignored at the moment. But the kinds of things that sit underneath all three of these provide some really powerful opportunities for win-win-win responses. We've seen a lot of, in many cases, I think, rather naively optimistic talk of build back better, because sure, there's been a load of, there's a huge opportunity here, but actually what we're seeing is increasingly is that we're getting more cars on the road. People are saying they're going to start flying again as soon as they can, and so on and so forth. So I think we need collectively to take a step back from just looking at what the immediate problems are and think, how are we going to really deal with the common themes that underpin environmental degradation, pandemics, and non-communicable diseases? And that's things like a hugely dysfunctional food and agricultural system globally that is fundamentally subsidizing unhealthy products, is leading to deforestation, that's generating carbon emissions, it's removing habitats so that animals are coming into closer contact with humans, it's promoting obesity, which makes people more vulnerable to these kinds of diseases. And actually dealing with these things in ways that promote health, in ways that could ultimately benefit the economy as well, is a huge set of challenges that we're certainly not going to solve with 25,000 words in the Lancet, but we're keen to identify them, expose them, and really think through the ways in which we can make clear the kinds of actions that not only need to happen, but reasonably could happen over the short, medium, and long term.
I think it sounds like, yeah, when you put it like that, there's this whole situation nested within a much broader set of issues that are going to have to be addressed, that is, yeah, encompassing all sorts of different government departments and different strategies. I mean, I know you're an expert on complex system problems and the like, Harry. It sounds like yeah, every time you think you get to the bottom of something, there's just another layer of complexity whereby this, yeah, the kind of global food system feeds into it.
But yeah, well, yes, but I think one of the keys to unlocking all this is absolutely not to obfuscate people by just throwing complexity at them. And one of the paradoxes of working effectively in complex systems is that actually grappling with that complexity, if you do it well, can simplify things. It can help you to see that what looks like just a mess actually does have some common themes and some common drivers, common actions, and it's possible to see a way through what might just look like a fog if you try and apply rather more traditional linear ways of thinking about causation. You kind of lose the point. And if you step back from that and see it as a complex system, it really is bizarre, but it paradoxically can simplify things. But I mean, the risk is that you just obfuscate and you get it wrong and you complexify things. So it needs to be done well.
Yeah, absolutely. And I don't know, Tracy, does that strike a chord with your experience of, again, dealing with public health more generally, that you have, all of these different areas that interlock, if you think about like housing and food policy and again, these interactions with kind of the choices, as you set out when you talk, that actually we talk about people's lifestyles, and actually a lot of the time it's not a choice, because if you're choosing between heating and eating and you've got limited food budgets, and so do you recognize that as Harry talks about, this kind of actually seeing the whole big picture can actually be very helpful, and then paradoxically simplify things as a way to then try and address these issues that play out then in a public health outcomes.
Yeah, and this isn't a new area. I mean, Dahlgren and Whitehead drew their picture of the wider determinants back in 1998 or thereabouts. This concept isn't new. I think we think about it more sophisticatedly because we have gone into that broader sense, because we're bringing the environment more into this. But certainly the conversations that I'm having, wider determinants are front and centre. And we know that we can't talk about people in isolation to where they work and where they go to school and where they live. All of these things have a massive impact on us. It isn't just about quality of housing, but it is about, we talk about deprivation and people always think that's about money, and it isn't always. It can be about rural deprivation, it can be about deprivation of access, and is that about where we live, or is it about our ability to access services independently, or are we making our services suitable for the user rather than suitable for the service? And it's how we think about these things a little bit differently. But the wider determinants and the social determinants of health are certainly front and centre in every conversation that certainly I'm part of. So there is a move, and we'll talk about this, Marmot's talked about this, there is a lot of good, solid grounding for this information. So we know that we've got to talk about our communities in the round and some people within their context.
I think that's, for me, one of the things that from everything that you've said this evening and from Harry's comments as well, that's come across very clearly is this need to approach situations in the round, but also very clearly that sense that you need to get into the communities and a kind of ground up from the grassroots upwards, rather than kind of imposing structures from the top, and going about it that way. I think that community engagement and the community buy-in and cohesion is very clearly something that's come across for me. I think we have had a chance to answer a lot of the questions, but we're pretty much, that's the time now. So it just remains for me to say thank you very much again, Tracy, for a fantastic talk. A lot of people, as I said, a lot of people have put comments in saying really enjoyed this hour, and an hour with Tracy is an hour well spent, was a comment I particularly liked that came in. I think we'd all echo that. So thank you very much Tracy. Yeah, thank you very much, Harry, as well, for your thoughtful contributions. And thank you to everyone who's tuned in and joined us online today. As I mentioned.